Thank you for inviting me to present our real-life clinical data on impeller support for patients with Takotsubo syndrome and cardiogenic shock. So Takotsubo syndrome is a very peculiar disease. It's a rather rare disease, so an estimated 2 to 6% of patients presenting with symptoms of an acute coronary syndrome are in fact patients with Takotsubo syndrome. And the hallmark of Takotsubo syndrome is a severely reduced left ventricular function. You can see here some examples of apical Takotsubo syndrome. 90% of those patients are women. And this patient here is a young man supported with a VA ECMO during Takotsubo syndrome. So those patients usually present with chest pain. 75% of patients have angina, and nearly 50% of patients have ST segment elevation, making it a clinical mimic of ACS. But in fact, Takotsubo syndrome is a prototypical acute heart failure syndrome, since systolic left ventricular function is more severely depressed compared to age and gender-matched ACS patients. And if you see here, we plotted end-diastolic pressure against ejection fraction. So the majority of patients have combined systolic and diastolic dysfunction. In fact, the prognosis of patients, not only in short term but also in the long term, is worse compared to the general conception. So the disease is underestimated, and you can see that 10% of patients go into cardiogenic shock or present already with cardiogenic shock on admission, and an estimated 4%, depends on the cohort, so 2 to 6%, die in hospital, making it a disease which is in the short-term prognosis equal to patients with STEMI, according to recent registries and studies. So the problem is, once a patient goes to cardiogenic shock, it's difficult to treat those patients because I don't need to explain to you why we want to avoid catecholamines, but Takotsubo syndrome is supposed to be a syndrome which generates through a spillover of catecholamines, which was published in 2005 in the New England Journal. So the sympathetic nervous system plays an integral part in pathogenesis of the disease, which makes all inotropic agents, let's say, like a poison for the disease. The good news is that systolic function in Takotsubo syndrome, as long as the patient survives the acute phase, recovers per definition, making it a prototypical disease which can be bridged to recovery. So when we talk about MCS in those patients, the major devices are VA ECMO and Impella. The IBP has been left for some years due to studies in AMI-related shock, but a specific hallmark of patients with Takotsubo syndrome is outflow tract obstruction in up to 20% of patients, making IBP even harmful in those patients. So the hypothesis was that Impella support is effective for bridge to recovery in patients with Takotsubo-related cardiogenic shock. We had some challenges to collect patients, since Takotsubo is already a rare disease, and we asked several centers in Europe and the US to collect data on patients with Takotsubo syndrome supported with Impella in cardiogenic shock. This is the baseline characteristics of the patients. So the patients are a bit younger and more frequently male compared to a standard Takotsubo cohort, making our cohort a more high-risk Takotsubo population, and we had more physical triggers which are independently associated with adverse prognosis during hospitalization, and these are the contributing centers in this cohort. This is data from 20 patients, and you can see that left ventricular function was severely reduced, mean 22% ejection fraction. We had 2.3 different catecholamines per patient, so patients in severe cardiogenic shock, and the majority was supported with an Impella CP or Impella 2.5, and one patient from Düsseldorf, I remember, was supported with a 5.0. 4 patients died in our cohort, making a survival of 80%, but you have to consider that one patient died from bleeding after preclinical thrombolysis, so this cannot be considered a failure of the Impella to support this patient during shock. And another patient from Hanover died after withdrawal of therapy due to a newly diagnosed metastasized cancer. In all other remaining surviving patients, left ventricular systolic function, as defined per Takotsubo syndrome, characteristics, all patients had recovery of left ventricular function. Then we searched for predictors at baseline. Are there any factors that we can judge on for survival or mortality? And there was basically no signal from the baseline characteristics. It's of course a small sample size. But what we could see here is that the patients who did not survive had a lower blood pressure and a higher heart rate, maybe suggesting that Impella support came too late in those patients who did not survive. So to summarize, cardiogenic shock occurs in 10% of Takotsubo syndrome patients, and mortality is 10 times higher than in patients with Takotsubo syndrome without cardiogenic shock. But conventional management, especially medical management of cardiogenic shock in Takotsubo syndrome, is pretty difficult. And outflow tract obstruction frequently complicates cardiogenic shock in Takotsubo syndrome. But LV function recovers in all patients, per definition, as long as you survive the acute phase, making the device a prototypical bridgeable disease. And in this first series of patients with Takotsubo syndrome and cardiogenic shock and Impella support, survival was 80%. But 2 patients died from causes not related to shock. So if patient selection would be perfect and no emergency physician applies preclinical thrombolysis, maybe survival could even be higher. LV systolic function recovered in all survivors, and prospective studies are of course needed to confirm safety and efficacy of Impella support in this special patient population. I want to close with this proposal. It's of course my own thoughts about the management of patients with Takotsubo syndrome and cardiogenic shock. So the patient who is in a refractory arrest is a very good candidate for VA ECMO as long as some prognostic factors are considered, and the patient who is hemodynamically stable with Takotsubo syndrome needs close monitoring and conservative management. The pre-shock cohort is a very special one because you need to closely monitor those patients, EDP, heart rate, Swan Ganz catheter, to re-evaluate whether or not the patient needs early mechanical circulatory support. And in patients with established shock, you need to check for aortic regurgitation, which is a well-accepted contraindication for most devices. In patients with outflow tract obstruction, this can be reverted by reducing inotropic agents, for example. So you need to check whether medical management is perfect and can revert this complication here and then revert shock without any MCS device. And in all other remaining patients, up to now, LV unloading seems to be the management of choice for those patients in shock with this special disease. So we now want to proceed with this registry and collect some more data on those patients in this prospective manner. So in case you want to join, just drop me an email, and we want to give you then a CRF form to collect some more data that we have complete follow-up in Swan Ganz, for example, of those patients. Thank you.
Yeah, Christian, thank you very much for this nice presentation and the very interesting and encouraging data on the survival, which is for patients that arrive similar to the ACS shock patients with 80% plus on support, certainly much better than we see it for cardiogenic shock in acute MI in many places. Are there any questions from the floor?
It was a great presentation. I have a question for you. I couldn't help but notice the high prevalence of the Impella 2.5. And that's a little bit counterintuitive because our default is the CP, and if we need more support, we use 5.0. If we can't fit a CP, we will use the 2.5. So what was the rationale behind so many 2.5s?
True, so I completely agree. I would never implant a 2.5 in a patient with established shock. If CP is manageable to implant in those patients. This was, of course, a retrospective cohort, and we had some centers that collected early patients. So let's say 5 or 7 years back, the 2.5 was more on the market than today. So this is possibly the explanation for the high number of 2.5 patients.
Really great talk. With Impella support, do you think that there's reduction in beta-adrenergic stimulation that's driving the underlying pathophysiology of the Takotsubo syndrome. There was a paper published looking at neuropeptide Y, looking at epinephrine and norepinephrine levels in patients. So do you think the idea of mechanical support starts to accelerate the washout, and maybe that's why there's a beneficial recovery effect?
So right now it is still a hypothesis that high levels of epinephrine, for example, or norepinephrine drive the disease. Maybe it's also an epiphenomenon that the patients are in shock and then have high levels of adrenergic hormones in peripheral blood. But of course, it's very suggestive that MCS with the Impella device may decrease those levels and lead to early recovery of systolic function. In this retrospective cohort, we do not have any echo data during support to judge how fast LV systolic function recovered. We just have systolic function at discharge, which is of course important, but we cannot compare this to a cohort without Impella support to know how fast systolic function recovered. Interestingly, the support time was very short, so we had a median support time of 2 point so and so on days in a range from 1 to 7 days in this cohort. And this rather short support time compared to AMIX suggests that systolic function recovers rapidly in those patients.
Yeah, and I think that gets to the origins of Takotsubo for stress cardiomyopathy, this neurocardiogenic axis. And if there was a way to evaluate, whether it's, circulating hormones of adrenergic tone versus direct sympathetic innervation of the heart, a lot of this idea of earlier recovery with mechanical support may be, again, because that initial emotional stressor or physical stressor is now allowing for more washout. So that may be some of that signal there.
True. So very likely circulating levels of those hormones are important for the disease, even if they do not induce the disease. They may maintain the disease. And there is only 2 patients, one from our hospital and one is published from another center, with Takotsubo in a transplanted heart. So the disease requires an anatomic connection between brain, nerves, and the heart, and both patients in the transplanted heart, that was for years after transplantation, so maybe re-innovation already took place.
Bill?
It was a wonderful review, and thank you very much for collating it. We had a couple of patients in your series, and I really appreciate you putting all of this together. Along the lines of what Naveen suggested, perhaps we should be more aggressive with this earlier use of Impella and earlier discontinuation of inotropes may actually allow for more rapid recovery. So I'm wondering if you have any data sort of longitudinally to see how quickly the ventricles kind of return to normal. The question is, if you support them very early and decrease the inotrope, do you get a much more rapid resolution of the LV dysfunction?
True, so thank you very much for your comment. Right now, I do not have any prospective randomized studies to support my own behavior in the clinics. But if I treat a patient with, for example, anterior MI and the patient goes into shock on the ICU, or a patient with Takotsubo syndrome and the patient goes into shock, and would in former times have received inotropes, I would not even start inotropes, I would implant an MCS device, to be honest, but it's my own behavior, so I cannot, I cannot present you any studies completely supporting this behavior.
Great, thank you very much.